Hydroxychloroquine, its role in diabetes. For this topic, we have two speakers with us, Dr. P.P. Chakraborty and Dr. Arjun Baidya. Respectively, I would like to introduce them. Both of them are endocrinologists. One we have from Calcutta Medical College and Dr. Arjun Baidya is from NRS Medical College. To chair the session, I would like to invite Dr. Somnath Noshkar and Dr. Mridul Bera. Talking about Dr. Noshkar, he is an active general medicine practitioner with special interest in medical education service, and going by Dr. Mridul Bera, he needs no introduction. He is a very eminent practitioner of Howrah and he is also a backbone of HDS. We welcome you, sir. We welcome the speaker and the chairpersons.
Very good afternoon. We have reached, we are moving towards the end of our session, program today. The audiences are less. Anyway, who are present, thank you all. And the molecule hydroxychloroquine, it's, to start with, it was anti-malarial, and it was, when it was used in huge number in, during World War II, then people discovered its effect on immunology, immunomodulating effect on rheumatology. And of late, some researchers are going on to prove its anti-diabetic effect. And to enlighten on this topic, we have two eminent endocrinologists. So for the next 40 minutes, the floor is all yours, Dr. P.P. Chakraborty and Dr. Arjun Baidya.
Thank you, chairpersons. Very good evening to all of you. At the outset, I must thank the team HDS for the kind invitation and having me here this evening. So you must have seen this slide at least 100 times before in different CMEs. In fact, Dr. Bhattacharya has already shown it. The global prevalence of type 2 diabetes between 20 to 79 years of age as per the recent IDF Atlas, the current status and what is predicted to be in the future. What you people might not have seen this is the total health expenditure of different countries attributed to individuals with type 2 diabetes. The US spends a lot, and India, despite being ranked 4th globally, the per capita expenditure is significantly less compared to the other developed nations. So despite such a huge expenditure, despite our claim of improvement in diabetes care, at least 50% of individuals across the globe having type 2 diabetes reach an A1C target of less than 7. So the next question is, why does that happen? What are the possible underlying reasons? My question is, do we know the pathophysiology of type 2 diabetes? Probably no. During my PG days in earlier part of the century, I was taught that the pathophysiology of type 2 diabetes is quite simple. On one hand, you have insulin secretory defect. On the other hand, you have insulin resistance at the level of the liver, at the level of periphery, you have type 2 diabetes. And the idea mooted from Ralph DiFranjo's the triumvirate model. But 22 years down the line, in 2009, the same gentleman, Ralph DiFranjo, came out with the concept of ominous octet. So now we know that the pathophysiology of type 2 diabetes is complex, is multifactorial, and perhaps yet to be crystallized. That's why smart people has come up with smart concepts. Beyond DiFranjo's ominous octet, they suggested that abnormalities of the catecholamine secretion from the CNS, the RAS overactivity, testosterone deficiency, and probably vitamin D deficiency play also a role in the pathophysiology of type 2 diabetes. And gentlemen, this is not the end of the story. Now we have treacherous 13th, the faithless 14th, or even forbidden 14th and formative 15th. So what does that mean? It basically tells us that even in 2019, we do not know the pathophysiology of a disease known as type 2 diabetes, a disease that you and me treat day in and day out. Coming back to the glycemic status, less than 50% of individuals across the globe reach a target of less than 7. The figures are even dismal in India. Less than 20%, yes, I repeat, less than 20% of individuals having type 2 diabetes in India reach a target level of A1C of less than 7. And the figures, they have not changed from 2011 to 2013. In fact, the figures have not changed from 2001 to 2013. Once again, what are the underlying reasons? Yes, we don't know the pathophysiology of type 2 diabetes. Compliance cost is an important factor in our patient, and probably there are certain abnormalities in the Indian population as well. We know that the Asian Indians are at 2 to 3-fold higher prevalence of insulin resistance compared to the Caucasian counterparts. Diabetes in our patient develop pretty early, a decade or two earlier than the Europeans. They have high incidence of CAD, and that too, the CAD develops much earlier. Compared to 2000, when NUDS study was done, in 2004, the onset of diabetes was a bit earlier compared to the NUDS as seen in the CURE study. This is the so-called, the famous YY paradox, much talked about. For a same BMI, an Asian has a much higher body fat, visceral fat to be more specific, compared to an European. This is a very nice concept, a pictorial depiction of the metabolic capacity and the metabolic load. The figures in gray, they depict metabolic load. Because of the quote-unquote thrifty phenotype, we, the Asians, do not develop that amount of metabolic capacity. However, because of unhealthy lifestyle, because of high calorie food intake, the metabolic load is much higher. So metabolic load is much higher than the metabolic capacity, so you get a positive energy in the form of visceral adipose tissue. This is a very recent publication in Diabetes 2016. They identified an adipokine, a cheimerin, that begets inflammation in the visceral adipose tissue. Because of excess visceral adipose tissue, because of excess adipokine known as cheimerin, there is inflammation within the visceral adipose tissue. So to cut a very long story short, high metabolic load, high calorie intake ultimately develops in excess visceral adipose tissue, which in turn produces insulin resistance and insulin secretory defect because of excess circulatory inflammatory markers. TNF-alpha was shown to be associated with insulin resistance long back in 1994. It acts on the insulin receptor substrate 1, and thereby it produces insulin resistance. Another marker of systemic inflammation is total white cell count, and a high white cell count can independently predict the risk of diabetes in the future. There are evidences to show that hsCRP, a well-known and a well-established inflammatory marker, can predict future risk of diabetes. And interestingly, the risk of diabetes is directly proportional to the level of blood level of hsCRP. In addition to hsCRP, interleukin-6 can predict progression of dysglycemia as well. There are different studies looking at different inflammatory marker, but the conclusion remains same: high inflammatory marker, be it CRP, be it fibrinogen, be it interleukin-6, can predict future development of diabetes. This is another meta-analysis. Look at the confidence interval, much higher than 1, suggestive of pro-inflammatory cytokines are associated with excess risk of diabetes. The gastroenterologists, they are saying that type 2 diabetes is a GI disease because gut microbiome plays an important role in the pathophysiology of type 2 diabetes. So the time has come that rheumatologists are saying that no, diabetes is not an endocrine disease, it's an inflammatory disease. So everyone is trying to snatch diabetes from us, the endocrinologists. So not only inflammation plays an important role in the development of type 2 diabetes, inflammation also plays an important role in the complication of diabetes. All the microangiopathies, the so-called triopathies, are related to systemic inflammation, and along with those microvascular angiopathies, macrovascular angiopathies are also higher if your baseline C-reactive protein is high. The overall mortality also depends not only on the component of metabolic syndrome, but also at the level of the baseline CRP. Much higher the CRP, if you have metabolic syndrome, you are at risk of early mortality. During my PG days, this was my thesis topic, I tried to look at the relation between C-reactive protein and different microvascular complications, and in my cohort, microvascular complications are much higher in individuals having high CRP. So ladies and gentlemen, to conclude, there is a definite link between inflammation and not only type 2 diabetes, but the whole spectrum of metabolic disease, be it metabolic syndrome, be it pre-diabetes, be it type 2 diabetes. In addition, different diabetic complications, be it microvascular or macrovascular, the risk, the incidence are much higher if the systemic inflammatory markers in the body are high. So I am eagerly waiting for DiFranjo's next model, in which he incorporates the gut microbiome and systemic inflammation and come up with a new model probably known as the dangerous dextrate. Thank you very much, ladies and gentlemen. Thank you very much for your patient hearing.
Thank you, Dr. Thank you, Dr. P.P. Chakraborty, for excellent deliberation. Now, we will take the question after Dr. Baidya.
Please.
Okay, you can.
I would like to take questions now.
Sir, one
You
prize
can ask
question.
one prize question.
Okay, so I have not prepared for that. Anyway, I talked about YY paradox, right? One Y stands for Yudkin, the European gentleman. What does that other Y mean? One Y for Yudkin and the other Y for? Yeah, that's right.
Sir, please introduce yourself.
I'm Dr. R.R. Joshi from Howrah.
Thank you, sir.
Sir, a small token for you.
One or two questions you can ask. If there is no question, our next speaker is Dr. Arjun Baidya, who will speak for hydroxychloroquine, the role of hydroxychloroquine as an anti-diabetic agent, and the stage is set for Dr. Arjun Baidya.
Anyway, so very good evening. So first of all, I would like to thank organizer Howrah Diabetes Study Society, and personally I would like to thank Sanjay Da and Dr. Mridul Bera for personally inviting me to talk this topic in front of you. So a few minutes ago, Partho was talking about inflammation and diabetes link. So he told that Dr. DiFranjo, who is the one of the pioneer in diabetes field, in investigation of diabetes, and he described the ominous octet. And Dr. Partho also told you regarding the other dirty dozens and etc., etc. But actually, Dr. DiFranjo, who also described in between another octet, not on octet, it is a decadent decoplate, which is published in Nature journal in 2000, I think it is 2018. It is published in 2016 in Nature journal in Primer as a review article, who described this decadent decoplate. Along with this ominous octet, he described two other components, that is, one is systemic inflammation, another is vascular insulin resistance. Together, this 10 component is called decadent decoplate. So now you know that hydroxychloroquine is basically an anti-inflammatory drug, disease-modifying drug, and I think almost all the doctors present in this hall use this molecule in rheumatological disorder, and this molecule is already approved in our country as well. For management of rheumatoid arthritis as well as SLE, and latest addition is type 2 diabetes mellitus. And how this molecule got approval in management of type 2 diabetes mellitus, I will describe. So, I'm going back. So before going to the actual topic, this pharmacokinetics. So bioavailability is very good, approximately 74%, and Tmax is 3.2 hours. And it is metabolized in the liver to active metabolites, and half-life is very long, approximately 50 days. And 23 to 25% of hydroxychloroquine is excreted unchanged in the urine, and rest is metabolized through the bile, excreted through the bile. But the basic difference between the chloroquine and hydroxychloroquine, which makes this molecule for favorable in use in type 2 diabetes mellitus, is basically the addition of hydroxyl group at the side chain of chloroquine structure. So because of this presence of this hydroxyl side chain, this molecule is become less infiltrated through the blood retinal barrier, so it is also easily dissociated from the retinal pigment epithelium. So because of this characteristics, this molecule is usually less toxic in terms of retinal toxicity. So there are multiple mechanisms which address, which is present this molecule, which is used in management of in a type 2 diabetes mellitus. I will be describing one by one. One is inhibition of insulin degradation, and so before going to the first mechanism, I will recapitulate how the insulin is metabolized in our system endogenously. Insulin binds to its receptor at the cell surface, and thereby it forms an insulin receptor complex, which is internalized into the endocytic vesicles, and thereafter it got dissociated from the insulin receptor. Then the insulin receptor is recycled back to the cell surface and again become active to bind insulin, but the insulin which is present inside the cell is degraded by various insulin degrading enzymes. But what happens after hydroxychloroquine administration? Hydroxychloroquine, after entering into the cell, it alkalinizes the media. So thereby it inhibits degradation of insulin by inhibition of insulin degrading enzyme action. So the insulin receptor is again translocated to the cell surface, and active insulin molecule, which is intact insulin molecule, is again recycled to the insulin receptor and binds to the insulin receptor to act again. So this is the basic mechanism. So what are the evidences? You can see from these preclinical studies, as the hydroxychloroquine concentration increases, the insulin degradation percentage decreases. As you can see in the y-axis, hydroxychloroquine concentration increases, but insulin degradation is decreased. On the right side of the panel, you can see that as the hydroxychloroquine concentration increases, the endogenous insulin area under the curve is increased. Now I am coming to the second mechanism of action, that is reduction of inflammation. In rheumatological disorder, though it is a short cohort, in Sjogren's syndrome patient, it was seen that after administration of hydroxychloroquine for a period of 6 months and 12 months, it reduces hsCRP level. Not only that, it also reduces interleukin 6. So it reduces inflammatory marker. And that was also shown in clinical studies as well. In this paper, we have shown that this hydroxychloroquine molecule reduces CRP level, and that is well correlated with the reduction of HbA1c level as well. And that was also shown in subsequent papers as well, subsequent studies. Now I am coming to the third mechanism, that it improves insulin sensitivity. In this study, though it is again a pharmacodynamic preclinical study, it was shown that this molecule also increases the insulin sensitivity markers. As you can see, from the upper panel, you can see the insulin sensitivity increased after addition of hydroxychloroquine, but in the placebo arm, there was no increase in insulin sensitivity, rather there was decrement in insulin sensitivity after the follow-up. And in the lower panel, you can see another marker, which was disposition index. Again, it was improved with the hydroxychloroquine, but in the placebo arm, that was not improved, rather it was reduced. Now I'm coming to this another marker, that is adiponectin, which is an insulin sensitizing marker. You can see the total adiponectin level, low molecular adiponectin level as well as high molecular adiponectin level. All these markers were actually increased after administration of hydroxychloroquine, but in the placebo arm, there was no increment of adiponectin level. So that indicates that it improves insulin sensitivity. This is again from the preclinical study. As you can see, after administration of hydroxychloroquine for a period of 6 weeks, it improves insulin sensitivity. But after a stoppage of the hydroxychloroquine, again the insulin sensitivity decreased. But on the right side of the panel, you can see after administration of hydroxychloroquine, insulin resistance decreased, and which increased again after a stoppage of hydroxychloroquine after a period of 12 weeks. Now I am coming to the last mechanism of action, that is beta cell preservation with hydroxychloroquine. This is again from animal model studies. Here the investigator took 45 rats and they induced diabetes mellitus with estrotozosine injections. So they took 3 groups of rats. In one group they took healthy control, another arm they took estrotozosine induced diabetic rat, and another group they took estrotozosine diabetic rat who were treated with hydroxychloroquine. So what they found, they have showed that after a period of follow-up, the beta cell in the islets actually improved in the hydroxychloroquine treated arm compared to control group and non-treated diabetic group. As well as the alpha cell marker, alpha cell mass was reduced in the hydroxychloroquine arm. And this is very nicely depicted in this slide. As you can see in the upper panel, that was the before administration of hydroxychloroquine, islets of Langerhans structure was disorganized. But in the lower panel, after treatment with hydroxychloroquine, islets of Langerhans structure is reorganized again. And regarding the beta cell, you can see from the immunohistochemistry staining, the concentration of immunohistochemistry staining is less, that indicates less mass of beta cell. On the other hand, the hydroxychloroquine improves the beta cell mass, which was indicated by improved concentration of immunohistochemistry staining. Regarding the alpha cell, you can see the upper panel, the alpha cell immunohistochemistry staining is much more than the lower panel, which indicates that after administration of hydroxychloroquine, alpha cell mass is decreased. Now I am coming to the clinical studies part. So there are many studies with hydroxychloroquine in type 2 diabetes mellitus. Some are randomized controlled trials, some are observational, and many studies are from international bodies and some studies from Indian. So first evidence came in 1990, and then in 2002, Garsten et al. Again came up with the evidence that hydroxychloroquine reduces HbA1c in type 2 diabetes mellitus. In the first paper in 1990, Quantrato et al., they took 38 patients type 2 diabetes mellitus who were treated with hypoglycemic agents, oral, insulin and other anti-diabetic drug combinations. And the patients were followed up for 6 months after addition of hydroxychloroquine in one arm, 200 milligram thrice daily, and in the other arm, the patients were put on placebo along with the other existing medications. And after the follow-up period, they found that it reduces HbA1c by 3.3% in both the groups. And in the insulin-treated patients, in the subgroup, that it was showed that the insulin requirement decreased by 30% as well. And these evidences were subsequently also supported by the other investigator. Now I'm coming to this very recent international study from this group, randomized double-blind placebo-controlled trial of hydroxychloroquine versus placebo. They took type 2 diabetes mellitus again, more than 60 kg, HbA1c was more than 8% baseline, and treated with metformin optimum dose and glimepiride also optimum dose. And they added hydroxychloroquine as a third line versus placebo and followed up for a period of 6 months. So there was significant improvement in glycemic parameter in hydroxychloroquine treated group, as you can see on the left side of the panel, fasting, postprandial, as well as the on the right side of the panel, you can see the HbA1c change after a period of follow-up of 24 weeks. And the lower panel, you can see the absolute reduction of fasting blood glucose in the hydroxychloroquine was 60 and postprandial was 135 and HbA1c 1.3% point. And that was significantly higher than the placebo group. Now I'm coming to this another paper, again head-to-head comparison of hydroxychloroquine with pioglitazone, the previous one versus placebo, and this is active comparator versus third line as a third line, hydroxychloroquine 400 milligram versus pioglitazone 45 milligram, which we usually do not use. We use up to 30 milligram daily. And at the end of follow-up, it was shown that the hydroxychloroquine 400 milligram reduces HbA1c by 1.2%, and both the drug was well tolerated. And pioglitazone caused significant body weight gain. But on the other hand, hydroxychloroquine, there was minimal body weight reduction. Now I'm coming to this landmark paper regarding the hydroxychloroquine. I call this paper the landmark paper because of those, after the publication of the study result of this paper and submission of this study result to the DCGI approved this molecule for management of type 2 diabetes mellitus, who are uncontrolled on diet, exercise, and metformin and sulfonylurea. So this paper was published in 2014, and Dr. Parekh was the principal investigator of this paper, one of the principal investigator. So what the investigator did, they took 806 patients for eligibility assessment, and ultimately they randomized 267 patients. And the baseline HbA1c was in between 7.5 to 13%, and fasting was more than 130, postprandial was 180. But they put the patients, after initial scrutiny, they put the patients in run-in phase and ultimately randomized 267 patients into two arms. In one arm, they put the patients on hydroxychloroquine 400 milligram. In another arm, they put the patients pioglitazone 15 milligram. So again, this is an active comparator study. You can see the result here after a period of 12 weeks and 24 weeks. So there was significant reduction of fasting, postprandial, as well as HbA1c reduction in both the group, but at least in the regarding the postprandial blood glucose reduction, numerically there was better reduction of postprandial glucose in the hydroxychloroquine arm, 39 versus 28, and after 24 weeks, 38 versus 25. So because of this study result, and considering the other study results, previous study results, DCGI approves this molecule for management of hyperglycemia, uncontrolled hyperglycemia, on the top of diet and exercise, metformin and sulfonylurea, the optimal dose. And the dose is 400 milligram daily. So after approval of this drug, again the sponsorer, they planned another study, which is phase 4 study. This is again for efficacy study and safety, as well as in the this is versus placebo. This is a phase 4 study, multicentric study, and this study is still ongoing, and I am a part of this study in our institute. But this is the interim result analysis, which was presented in 2018 ASC meeting last year in Boston. And here it was shown that in the subgroup analysis, those who had baseline hsCRP more than 3, they had better reduction of fasting and postprandial blood glucose, versus they had less than 3 hsCRP level. On the top of that, there was an interesting finding in this study that total LDL and non-HDL cholesterol and triglyceride also reduced significantly in both the groups. But interestingly, the percentage change in LDL-C was significantly more in the subgroups, those who had baseline higher HbA1c level. Now I am coming to the observational studies. Till now I described the randomized control trial. This is the first observational study, but this is again a retrospective prospective study, but with a different cohort. This is a rheumatological cohort. In this cohort, more than 4,000 patients the investigator analyzed, and they showed that after a follow-up period of 21 years approximately, those patients who received hydroxychloroquine for a period of at least 4 years, they had 77% low risk for development of new onset diabetes mellitus. So this was I think this was the first observational evidence that hydroxychloroquine can prevent development of new onset type 2 diabetes mellitus. Thereafter, many observational studies published in different journals. There are many studies versus telinagliptin, versus vildagliptin, versus sitagliptin, as a follow-up with hydroxychloroquine on the existing drug, versus add-on to insulin, and hydroxychloroquine versus telinagliptin again, hydroxychloroquine, sitagliptin, hydroxychloroquine replaced by hydroxychloroquine was replaced on the place of telinagliptin, and again hydroxychloroquine versus sitagliptin, and add-on treatment to hydroxychloroquine 400 mg. But in all the observational studies, it was shown that this molecule reduces HbA1c level significantly, approximately by 1%, and all the trials duration was approximately 24 weeks. And after approval of this molecule and publication of many articles in the different literature, our national body, research organization regarding the diabetes, that is RSSDI, they also endorsed this molecule for management of hyperglycemia in type 2 diabetes mellitus. Now I'm coming to the safety part regarding the cardiovascular safety and other safety issues as well, and mechanism of cardiovascular protection. So this was the study where it was shown that, again from a rheumatological cohort, this is a retrospective one. What the investigator did, they took a very large cohort, more than 1,000 patients, more than 1,200 rather, and they divided the patients into two groups, those who received hydroxychloroquine and those who did not receive hydroxychloroquine. In this study, in this analysis, they showed that those who received hydroxychloroquine, they had 72% less risk for development of CVD in the long run. Well, what is the mechanism of CB protection? So there are many mechanisms. One is anti-inflammatory, but apart from that, there are many mechanisms in this study. It was shown that it reduces LDL-C level as well on the top of atorvastatin. What the investigator did, they took two cohorts. One cohort divided into two arms. In one arm, they put the patient on atorvastatin alone. In the other arm, they put the patients on atorvastatin along with hydroxychloroquine. And it was shown that this molecule, when it is used in addition to atorvastatin, reduces total cholesterol, LDL-C cholesterol, and non-HDL cholesterol. All the three parameters it reduced significantly in comparison to atorvastatin alone. This is another slide regarding the evidence for mechanism of cardiovascular safety. This is from HEAT study. This is a proof of concept study. In this study, it was shown that this molecule, hydroxychloroquine, when it is added for measuring a platelet aggregation, it actually reduces platelet aggregation induced by arachidonic acid as well as adenosine diphosphate. But it did not reduce the platelet aggregation when it is induced by collagen. On the right side of the panel, you can see this molecule also increases the percentage inhibition of platelet aggregation when it is added on the top of aspirin and as well as on the top of aspirin versus aspirin alone. Now there are many other studies, ongoing studies regarding the cardiovascular safety. One is OXY trial, which is planned with 2,500 patients, those who are hospitalized for myocardial infarction, and they were treated with hydroxychloroquine 300 mg per day or placebo for at least 12 months and until 350 CV events occurred. And the primary endpoint is composite of death, MI, hospitalization for unstable angina, urgent PCI, and or urgent CABG. And there are other studies which are, some are planned and some are ongoing. Now I'm coming to the other safety issues. Some are long-term issues, some are short-term issues like GI side effect. Immediate side effect profile, adverse effect is GI side effect, which can be overcome by administration with low doses and subsequently up titration of the dose and prescribing the drug after dinner. I am coming to the long-term safety issues regarding the retinal toxicity, which is an important issue with this molecule. As I have told, that this molecule has got difference in comparison to chloroquine because of the presence of hydroxyl side chain. So because of this presence of hydroxyl side chain, it is less toxic to the retina. That was also shown in this study. It was shown that there is low risk for development of retinal toxicity, those who treated with hydroxychloroquine, but mind that this cohort is again from rheumatological patients. And those who received hydroxychloroquine less than 5 milligram per kg of body weight per day, they had less risk for development of retinal toxicity, approximately 1% after a period of 5 years. And those who received more than 10 years, they had less than 2% risk. These are the risk factors for development of retinal toxicity. One is daily dose, as I have told, duration of the dose, renal impairment. Those who has renal impairment, they had increased risk, concomitant drug use, and pre-existing macular disease like macular degeneration or any other pre-existing macular pathology. Now I'm coming to the screening part when you use this molecule in type 2 diabetes mellitus. But again, mind that there is no recommendation in type 2 diabetes mellitus for screening when the patient is getting hydroxychloroquine. This is from, again, rheumatological cohort. But if you remember that in type 2 diabetes mellitus, the screening for retinopathy for type 2 diabetes mellitus, even if the patient is not getting hydroxychloroquine, the recommendation is annually, baseline and thereafter annually. So in this recommendation, AAO, American Association of Ophthalmologists, they recommend the fundus examination within the first year of use, if it is not done at the baseline or initial follow-up, and add visual field and or SDOCT if maculopathy is present, and thereafter annual screening every year after 5 years of use, and sooner if there is presence of major risk factors. And this Royal College of Ophthalmologists, they also recommend the same guideline. Now I'm coming to another long-term or rather semi-long-term issues is hyperpigmentation with hydroxychloroquine. This is again, but from a rheumatological cohort, in a SLE cohort, though the cohort is very small, the incidence rate is 7.3% after use of 6.1 years, but there is no study with hydroxychloroquine in type 2 diabetes mellitus regarding the incidence of hyperpigmentation. But I think this is underestimation of the hyperpigmentation report. I think clinically we see more frequently hyperpigmentation when we use hydroxychloroquine, and particularly with a short-term use after a few months of use. Say after 5 or 6 months, the patient can develop hyperpigmentation. Now I'm coming to other issues, particularly hypoglycemia. As this molecule reduces HbA1c level or fasting or postprandial blood glucose level, there is chance for development of hypoglycemia when this molecule is used with sulfonylurea or non-sulfonylurea secretagogue or insulin. But when you use this molecule along with metformin only, there is no chance for development, there is very less chance for development of hypoglycemia. So now the next question is, what are the contraindications for using this molecule? So obviously the hypersensitivity to any drug is a contraindication for use of that molecule for in future. So this is a strong contraindication. And pre-existing retinopathy, particularly moderate or severe retinopathy or pre-existing maculopathy, is another contraindication. And retinal or visual field changes, which is attributable to 4-aminoquinone, is another contraindication for using this molecule. So the take-home message is hydroxychloroquine reduces HbA1c level significantly in the range of 0.9 to 1.3%. And additional benefits of this molecule, when you use this molecule in type 2 diabetes mellitus, is this molecule also reduces lipid parameters, improves lipid parameters. It also reduces body weight, though it is marginally. So it can be started in any patients who is uncontrolled on diet and exercise along with optimum dose of metformin and sulfonylurea, and the dose is 400 milligram daily. And the risk for retinopathy after 5 years is very less, and after 10 years is 2%. And American Ophthalmological Association recommend initial ophthalmological follow-up within 1 year of starting this hydroxychloroquine and thereafter annually. And if it is used for more than 5 years, SDOCT should be added in our annual screening protocol. So hydroxychloroquine is not an old drug. It is not a new drug. It is rather an old drug which find its new indications. So it is rather a sort of old wine in a new bottle. So thank you. So can I ask the price question now? Before taking the question, can I ask the price question? Only one. That is all. Oh, for this session, only one question. Okay. Sure. Because this molecule is investigated in type 2 diabetes mellitus patients. The other molecules, I think the methotrexate also investigated in diabetes mellitus patients, but the study results are not encouraging.
Sir, one question. I saw these studies are there since 2002. All the studies have been started since then. Now, being such a promising drug, why don't we have a larger randomized controlled trial which is concentrating on these triopathies also, including nephropathy, retinopathy? Why only just the diabetes, and the duration of the studies are 1 year, max 2 years? So why not beyond that? Why not with retinopathy? The study has been since 2002.
You know that first of all, to get approval for a new indication for a molecule, whether it is old one or a new one, you have to show the safety, you have to show the efficacy first, then the safety. Then after approval, you can go for further extension of the study and for the other indication as well. So I think the investigator or the sponsor will do it in the long run.
Okay, thank you, sir. And thank you, audience. We'd like to conclude the session now.